Today in the clinic we have Blake Griffin, a 30-year-old professional NBA basketball player who presents with left medial knee pain. After taking a full history and asking specific questions on the mechanism of injury, it was determined that as Blake jumped to catch the ball during a game, he landed and then went to pivot. This action caused his injury. The clinical examination revealed he had an antalgic gait, localized swelling over the medial left knee, and medial joint line tenderness on palpation. Active range of motion provoked pain on end range, with passive range of motion restricted due to pain. Positive orthopedic tests included McMurray, Thessaly, and Apley. This led to sending Blake for a gold standard MRI of the knee to confirm a suspected medial meniscus injury. Blake has been diagnosed with a low-grade tear of his medial meniscus, which is a tear or derangement of the semilunar medial fibrocartilaginous disc between the tibial and femoral condyles within the knee joint. A study has found that in the NBA, over a 21-season span, of 129 isolated meniscal tears, 52 of them were medial meniscus. The study also determined that of the 52 medial meniscus tears, 29 of them occurred in the left knee. Tears of the medial meniscus were more likely to occur over the age of 30. For Blake's treatment, we'd aim to reduce swelling, pain, and restore his normal biomechanical function. Here are some treatment options outlined. For Blake's rehabilitation, our main goals are to minimize the effusion, normalize his gait, as well as regain pain-free range of motion. To do this, we have developed a 4-stage rehabilitation program as summarized in this table.
The most common mechanism of injury for the meniscus is twisting while the foot remains planted. The goal for the initial stage of rehab is to decrease pain and swelling to allow for the eventual return of pain-free range of motion and adequate tissue healing and repair. Immediately following the injury, ice should be applied for 15 minutes every few hours to reduce swelling and provide symptomatic relief. It should not be applied directly to the skin and should be covered by a thin towel. Gentle exercises can be utilised in the initial stage, depending upon severity of the meniscal strain. Simple knee flexion and extension can be performed inside a pain-free range of motion. Isometric contraction of the quadriceps muscle can also occur in this stage. Depending on severity of strain, weight-bearing functional movements may not be advised as they place increased load throughout the already swollen joint and directly irritate the meniscus. Initial osteopathic treatment should begin gently with the aim to encourage fluid drainage and increase blood supply, allowing for tissue repair. Treatment techniques should mainly involve small amounts of joint traction and gentle articulation. Crutches should be used on the patient when ambulating to prevent excessive load throughout the knee, causing direct irritation to the meniscus. As time and healing progress, the crutches can be used as an exercise aid to place slight load throughout the knee, allowing for increased strength when moving to stage 2 of the rehab process. When considering hydrotherapy, there are a few main points that need to be taken into consideration. Patient's swimming ability and comfort around water, as well as recent knee surgery, are contraindications to hydrotherapy due to the risk of drowning and post-operative infection. The buoyancy of water acts to decrease gravitational forces through the knee and hence reduce the stress and load it takes when performing these activities. Hydrotherapy rehabilitation in the acute phase should consist of flexion and extension activities, double calf raises, as well as gentle weight bearing and walking.
Phase 2 of the rehab model is titled the intermediate pre-participation stage. This stage is reached when the patient is able to perform ADLs and has a good range of motion and is generally undertaken during the period 2 to 4 weeks post-injury. On a cellular level, the phase 2 should correspond to the partway point of proliferation or the repair phase of tissue healing. The goals of this stage are to completely eliminate swelling, achieve full range of motion, increase neuromuscular recruitment, and achieve a 4 out of 5 quadriceps strength and a 5 out of 5 hamstring strength. To achieve these goals, the exercises of this stage are therefore weight-bearing and generally closed-chain exercises. It is important to continue to do the isometric exercises done in phase 1. To start, we are going to teach a half squat. To do a half squat, the patient should stand with their feet just wider than shoulder width and their back should be straight. Squat down to approximately 45 degrees, or if pain is felt before 45 degrees, stop at this point and then return to standing. The patient should do 3 sets of 15 reps. You can progress this exercise by gradually increasing the depth of the squat, whilst ensuring no pain in the knee is felt. The next exercise we are going to do is a lunge. Start with a wide stance, step forward and bend your back knee towards the floor but don't let it touch. Ensure to keep your back upright and don't let the front knee move forwards past the toes. Do 2 sets of 10 per leg. This exercise can be progressed to lunging in a star pattern to enable increased range of motion, balance and proprioception. Calf and hamstring stretches are good to do in order to increase flexibility and maintain range of motion. To do a hamstring stretch, start by sitting on the floor with your legs straight. Then lean forward to try and touch your toes until you feel a slight stretch in your hamstrings. To do a calf stretch, start in the same position but put a resistance band on the balls of your feet. Pull back on the resistance band to dorsiflex the ankles until a stretch is felt in the calf. This can also be done using a towel or any other such object to pull the feet back. Each stretch should be held for 15 to 20 seconds and repeated 3 times.
In Phase 3, we move on to the advanced stage, otherwise known as skill acquisition, which is performed at about 4 to 6 weeks post-injury. It's an active and loaded phase that is progression of Phase 2, and it's all about preparing the patient for sport-specific exercises which will be completed in Phase 4 in return to their sport. We want to progress strength to levels to supernormal while promoting full pain-free range of motion, and we want to progress exercises from unilateral to bilateral while varying the speed of the tasks. 3 exercises relevant for Phase 3 are listed there, and I'll go into further detail with some videos explaining these exercises. In single leg balance, we want to start by standing on both feet with the feet pointing straight ahead. We then flex the knee that we're not working on to about 20 to 30 degrees, extending your arms outward to balance and positioning yourself upright with your shoulders above your hips and your hips above your ankles. You stand in this position until we lose balance, and you can progress this by standing on a foam mat or something to dorsiflex the foot. Wall squats are performed by placing your back against a wall and lowering yourself to your knees at about 90-degree flexion. We hold this position until we're fatigued and then we straighten up again, and this can be progressed by placing something such as a weight or a weighted object in the patient's lap. For box jumps, we start by standing with our feet shoulder width apart, getting into a quarter squat to engage the hamstrings and glutes, and then forcefully extending the hips to propel yourself up onto the platform. When landing, we want to think of absorbing the force in the muscles rather than in the joints, otherwise known as sticking the landing. And we want to hold the position for about 2 to 3 seconds when we land and then step back down. Ways in which we can progress these exercises is shown here.
Phase 4 is also known as return to sport. Phase 4 focuses on preparing the patient for return to their sport by getting them to participate in sport-specific drills and exercises. It is important that during this phase that previous rehabilitation exercises are continued as collagen maturation and remodeling continue for up to 12 months post-injury. So this drill is known as the zigzag drill. It focuses on acceleration and deceleration, which are commonly performed during games. Therefore, this drill incorporates movements which simulate a game situation to challenge the neuromuscular system. The 45-degree cuts address agility, change of direction, and power, while also improving cardiovascular fitness. The star drill is where the clinician calls out a number from 1 to 4 and the patient must run to that number and back to the starting point where the clinician will call out a new number for the patient to run to. This focuses on the player's ability to react to a verbal command and to change direction of movement. Dribbling can be added to this drill for increased functionality and it may improve the player's hand-eye coordination. The leap contact drill is where the player jumps from the ground off a 30-centimetre box and while mid-air, the player is pushed by the clinician. Contact sport can lead to injury, therefore it's crucial that the player is mentally and physically ready for the demands of the sport. This drill is designed to re-establish confidence in the player's ability to land with the proper mechanics and reduce the likelihood of injury occurring. To land in a protected, stable position, the player must land on both feet with knees and trunk flexed with no valgus force being placed through the knees. Contact drills should only be done in the final stages of rehabilitation. There are a number of criteria which should be taken into consideration when determining whether a patient is ready to return to sport. They include pain-free full range of motion, no persistent swelling, adequate strength, endurance, flexibility, proprioception, and balance, adequate cardiovascular fitness in proportion to workload required for the specific sport, skills are regained, no persistent biomechanical abnormality, and the athlete is psychologically ready. Contraindications to return to sport include persistent recurrent swelling, joint instability, loss of joint range of motion, and lack of full muscle strength.
Blake is on the path to successful healing of his medial meniscus tear. He has achieved a reduction in swelling, regained pain-free range of motion and biomechanical function due to the well-formulated, appropriate rehabilitation program. He can now return to the NBA and continue his sports career.